Senate leadership has decided that anybody that is wanting to comment, ask questions of any conferees or anything going on in committees, that they have to be present. I know we've kind of allowed it to, as long as you're here, you can communicate or ask a question remotely. They do not want us to do that anymore, so they've told us not to allow that. Also, if you are attending remotely and you want to be counted present at some point in time during the committee meeting, you do have to stop in and say that you are here and present, but you are attending remotely. That is from our Senate leadership, so we don't have a say in that, but I wanted to make sure all committee members were aware of that. So after that, we're moving on to bill introductions, requests for bill introductions. Tara, do you have a bill introduction?
Good morning, Mr. Chairman, members of the committee. I am Tara Mays with the Kansas Hospital Association. I appear before you to kindly request RS number 0754, establishing rural emergency hospitals as a rural healthcare licensure category and enacting the Rural Emergency Hospital Act.
Committee members, you've heard the request for RS 0754. Do we have any objections on this being introduced as a Senate Public Health and Welfare bill? Seeing none, that's introduced.
Thank you.
Do we have any more bill introductions? Okay, not seeing any. We will move on to our next order of business, and that is our continuation of a briefing on our special committee on mental health and modernization report. First up, we have Andrea Clark. She's with CIT Veterans Program Coordinator for KDADS. Andrea, are you there? Andrea, are you there?
Yeah, this is Andrea Clark.
Okay, Andrea, thank you for showing up and for your testimony today, and you have the floor. Thank you.
Thank you so much. Sorry, I was my co-chair was having some trouble signing in, so I was assisting with that. So thank you for the opportunity to share our work. Today, my name is Andrea Clark. I am the CIT and Veterans Program Coordinator and the Behavioral Health Commission at KDADS, and I was honored to serve as co-chair with this group along with Mr. Kessler. The first topic addressed by the System Capacity and Transformation Work Group was data systems. And we moved forward with this topic with the vision that a modern behavioral health system requires seamless real-time data systems with multi-directional data sharing among behavioral health providers, other healthcare providers and systems, community organizations, social service providers, law enforcement, and payers. We think it's helpful to consider that a modern data system functions really at two levels. Kind of at a macro level and a micro level, in that it provides useful, easy to access and analyze information from a systems level so that stakeholders, decision makers can get a really accurate snapshot of the system. And it also performs at a micro level so that there's efficient and secure exchange of personal health information to facilitate good care. With this in mind, our work group identified 4 recommendations for immediate action and 1 for strategic importance. The first recommendation we supported what in relation to the state hospital EHR, electronic health record. KDADS has issued an RFP to implement a new state hospital EHR, and the initial funding has been authorized. But the work group wanted to recommend this action so for ongoing support for the system for sustainability and for any potential future updates and challenges. The work group also wanted to emphasize that the EHR be interoperable with other state systems, particularly those that relate to Medicaid benefits. The next recommendation we put forth was around data and survey informed opt-out. This recommendation is that we collect, analyze, use, and disseminate surveillance data to inform prevention, and specifically that there's legislation change regarding public health and behavioral health state surveys, such as the Kansas Communities That Care survey and the Youth Risk Behavior Surveillance System surveys, that's changed from an opt-in consent procedure to allow for more meaningful data collection. The work group felt that this data was essential to inform prevention and mitigation efforts, and that the lack of data as a result of the change really has hindered the ability of the state to complete federal block grant requirements and other activities. The next recommendation that our work group looked at was utilizing Medicaid funds to incentivize participation in health information exchanges like the Kansas Health Information Network or the Lewis and Clark Information Exchange. This recommendation, the work group believed would lead to a better coordination of care. They didn't want to mandate participation in health information exchange for providers, and felt that incentives would be more effective to increase participation. Specifically, that you could utilize the Medicaid program through waiver amendments or federal innovation models, since previous incentives, particularly for behavioral health providers from federal funding, have expired or have concluded. The next recommendation that our work group advanced was around a statewide needs assessment for substance use disorder in the state. This was a recommendation developed by the Substance Use Disorder Task Force originally, and that a thorough needs assessment would examine funding, access to treatment across the state, as well as look at policies to encourage effective utilization, integration, and the expansion of STD treatment resources. The work group also wanted to emphasize that this would be an assessment completed on an ongoing basis, and that the STD system be continually reviewed. Lastly, the work group highlighted as a recommendation of strategic importance, just the need for state agencies to develop policies that improve cross-agency data sharing and making service and program decisions based on shared needs assessment. So really just the ability to collaborate within and across state agencies. This would help establish common goals across agencies, improve efficiency, and highlight where the gaps in care for vulnerable populations are that are served by multiple agencies. The next topic that the work group addressed was interactions with the legal system and law enforcement. The vision of the work group for this topic was that a modern behavioral health system allows for timely connection to services for those in crisis, and that it happens in the least restrictive setting that is appropriate to ensure public safety. That a modern approach increases access to treatment resources for those who are justice involved and provides training to law enforcement, courts, and the legal system to increase awareness of mental health issues and provide tools for appropriate response. The work group identified 4 recommendations on this topic, 3 highlighted for immediate action and 1 for strategic importance. The first recommendation was to expand training in correctional facilities to allow employees to better recognize substance use disorder and to use a trauma-informed approach to those in their custody. KDADS currently has some funding to provide law enforcement, first responders, and correctional employees at the local level training in mental health. The work group really wanted to emphasize the need to include substance use disorder and trauma-informed care in that training, and it expand across the state. The next recommendation, the work group wanted to recognize the significant work that's been done at this time by the Criminal Justice Reform Commission and other work across the state addressing behavioral health. That final report was released at the beginning of December, right as this work group's was concluding. And so specifically, the work group discussed supporting those report recommendations around expansion of pre and post-charge diversion programs for those with substance use disorder, and the support and expansion of specialty courts. And the work group also wanted to recommend that as the special committee's report is really considered a living document, that a process be developed to monitor the implementation and status of the recommendations of the Criminal Justice Reform Commission as well. Next, the third recommendation the work group we focused on was increasing the utilization of evidence-based SUD referral for those with law enforcement contact. This recommendation, the work group wanted to highlight the high incidence of substance use disorder among those with law enforcement contact. And again, discuss the importance of aligning recommendations and efforts with other work going on, such as the previously mentioned Criminal Justice Reform Commission, as well as the Supreme Court's recently released Pretrial Justice Task Force, two reports that weren't considered in the work we did on these topics. So one recommendation the work group wanted to highlight as a step the behavioral health system could impact the intersection of law enforcement is the implementation of the CCBHC model. As one requirement of the model is the development of partnerships between behavioral health providers and law enforcement. Finally, as a note of strategic importance for this topic, our work group recommended that an operational definition of crossover youth include behavioral health. Currently, crossover youth is defined by a DCF statewide crossover youth policy team as a young person aged 10 and older with a level of concurrent involvement with the child welfare and juvenile justice systems, inclusive of out-of-home placements, probation, immediate intervention programs, and voluntary preventative services. Our work group wanted to highlight the need this is a clear definition of which youth fall into the category, but also emphasizing the importance of behavioral health and how behavioral health is truly critical to serving those duly involved in the juvenile justice and child welfare systems. Next, the last topic our work group examined was systems transformation. This topic really addressed strategies that would transform the continuum of care to ensure an integrated and coordinated approach to care delivery. Discussion around systems transformation really focused on barriers related to cross-system collaboration, infrastructure changes, and Medicaid payment for services to families. The working group advanced a total of 5 recommendations, 3 highlighted for immediate action and 2 for strategic importance. First, our work group recommended the development of a regional model to supplement the traditional state hospital setting, with regionalized facilities accepting both voluntary and involuntary admissions for persons in acute services, as well as longer-term specialized care. The work group noted that there's a particular gap in capacity in South Central Kansas, and that this could be accomplished through the combined approach of the state institution alternatives policy that KDADS is currently pursuing, as well as looking at supporting smaller regional state facilities potentially. The next recommendation that our work group discussed was reform for nursing facilities for mental health. This is long-term care access and reform. Specifically, this recommendation was a high priority to the working group due to the importance of protecting the rights of citizens with disabilities by providing Kansans the opportunity to live and receive care in the least restrictive environment possible. The working group discussed the importance of NFMHs in the continuum of care, noting that limited access to these facilities really puts pressure upstream on the system as individuals who are not able to discharge from NFMHs due to lack of resources in the community potentially affect the number that can be admitted, and therefore affect the number of those that can be discharged from acute hospitals into a more appropriate setting. So this access to care was noted as particularly limited for individuals with past involvement in the criminal justice system and those who have a history of sexual violence. In addition to access to NFMHs, reform would also address improved quality of care with the provision of active treatment services within those facilities and better discharge planning to connect individuals to supports back in their community. The next recommendation for immediate action that we discussed was a focus on integration. So really increasing integration, collaboration, and care transition linkages between mental health, substance abuse, primary care, and emergency departments across the state. Integration in this sense was highlighted across several other reports and topics reviewed by the work group and others, and is really a major driver behind many of the actions that have been proposed, like the adoption of the CCBHC model and efforts to expand crisis stabilization services and mobile response. The work group focused particularly on how the adoption of certain coding practices can be seen as critical to the goal of providing best practice whole person care. And then of strategic importance, lastly, for this work group, we recommended that Kansas should continue the expansion and support of evidence-based practices in the state. This includes previous recommendations around housing and supported employment programs, and that evidence-based programming should be utilized across systems, including the justice system, SUD, mental health services, and that they should be utilized with the goal of implementing these programs to fidelity when possible. Finally, we advanced a recommendation to enable the utilization of a Medicaid procedure code to really support youth in foster care, as well as any child accessing care in psychiatric residential treatment facility, specifically related to family psychotherapy. This was a code that had been previously active in the state, but isn't currently, and would support the implementation of evidence-based programming called Generation Parent Management Training, which is a structured intervention designed to help strengthen families, and that the state has been working towards implementing with the Federal Families First Act. So that I conclude our recommendations, and available for questions now or at the end. Thank you.
Andrea, thank you very much. Committee, we're going to hold questions for conferees until after each one of them have had an opportunity to give their testimony. Next, we have Sandra Berg. She is the Executive Director of United Behavioral Health for CanCare.
Good morning, Mr. Chairman and committee. Can you hear me?
Yes, thank you.
Thank you for inviting me to give testimony this morning. I was part of the telehealth work group that was a compilation of all of the work groups that met under the special committee. And we looked specifically at telehealth and how it can impact the mental health services that are provided across the state. As you know, telehealth services were quickly implemented during the pandemic to address the needs of Kansas and to help them get access to services in a safe and efficient way. The rapid implementation of telehealth services has given us an opportunity to see what's been helpful and what other areas we have opportunity in modernizing the mental health system. The task force that worked on the telehealth recommendations wanted to ensure that the delivery of behavioral health services was meaningful, accessible, of high quality, and could be integrated across systems in Kansas. With the balance of in-person and telehealth options, consumers can choose the modes of delivery that best serves their needs. We came up with 5 recommendations, one of them having a lot of weight in quality assurance, and then looking at reimbursement codes, telehealth for crisis services. We looked at originating and distant sites, and then the child welfare system. Under quality assurance, we wanted to make sure that we established a high quality telehealth service. And by doing that, we would have consistent guidelines and measures for telehealth in collaboration with licensing and regulatory agencies. We'd implement standard provider education and training, ensure that patients have privacy during telehealth services, and then educating them on what their privacy related issues could be. Another area of topic under quality assurance was allowing telehealth supervision hours to be consistently counted towards licensure requirements, and then allowing services to be provided flexibly with broadband access where it's limited. Under reimbursement codes, there were several reimbursement codes that were added to the telehealth array during the public health emergency. A recommendation from the work group was to maintain some of the newly added codes during the pandemic. Allowing a person to receive services in their home has also led to a wider utilization of telehealth codes. Prior to the pandemic, only approved sites in an office could be the site for accessing telehealth services. The committee recognized the potential for loss of revenue, though, when the hosting site cannot collect their facility fee if a consumer is accessing services from the home. Under telehealth for crisis services, by accessing crisis services through telehealth, that would assist law enforcement and expand access to those services by connecting them to a local mental health professional. Having immediate access to a trained professional would generate savings by resolving crisis instances prior to a psychiatric admission. In the fourth recommendation, we looked at the originating and distant sites and looked at the definitions, and the recommendation was to expand the ability for folks to receive their services in their home or in a different place of service that would require less travel and more accessibility. The recommendation from the committee was to broaden that definition that would be consistent with the Kansas Telemedicine Act. Allowing consumers access to services in the privacy of their own home can give them more choice and potential engagement in their services. We feel like having that choice is going to help expand and give people the access that they haven't had previously in the past by having to travel distances, especially in the rural areas. We also understand that there are issues with practicing across state lines, and one of the recommendations was to explore that providers have the ability to practice across state lines and allow consumers to receive their services through interstate licensure compacts. The last recommendation we had was for the child welfare system and telehealth. By utilizing telehealth to maintain service and provider continuity, especially for our children in the foster care system who move frequently. By providing access to services immediately and with consistency, we can improve the outcomes of children who are placed outside of the home, as well as help resolve treatment issues that may be barriers to their reunification. And that concludes my testimony, and I will be available for questions at the end.
Andrea, thank you very much for your testimony. Up next, we have Rachel Marsh. She's the Executive Director for the Children's Alliance of Kansas. Rachel, welcome, and thank you for your testimony before the committee.
Good morning, Chair, Vice Chair, and members of the committee. Thank you so much for the opportunity to present for the working group on prevention and treatment. I want to first introduce myself, as I haven't presented in front of all of you before. My name is Rachel Marsh. I represent the Children's Alliance of Kansas, and we're an association of 18 child welfare service providers in the state. And so we have two main lenses that we brought to our work on this committee. One is that we see how the Kansas mental health system impacts our most vulnerable residents, children and families involved in the Kansas child welfare system. We also are direct providers of home-based, inpatient, and outpatient mental health and substance use treatment services. And so we also brought that lens in our contributions to the working group. We really greatly appreciated the opportunity to serve alongside behavioral health experts in the state. And I was very honored to participate as the co-chair of the working group, and will do my best to present the information from the working group, knowing that my expertise is limited on questions. I may call on other experts on specific topics to help at the end. We started off with 3 subgroups prevention and education, treatment and recovery, and special populations. We looked at the modernized vision for prevention and education to start with, and we thought that modernized efforts would really explore services with some common components. One is that we need to be exploring services from the lens of populations at increased risk for poor outcomes. That's going to be a modernized approach to prevention and education. We need to continue to prioritize suicide prevention. We need to look at points of entry and access into the behavioral health system, and we need to take a population-based approach in our services. We also need to make sure that our services are trauma-informed, along with the broader trauma-informed trend across the country, and to support looking at employment and other concrete supports so that people don't just have their mental health needs met, but can succeed in independence. There were 4 recommendations under the prevention and education subtopic, and so I'll go through those one at a time. The first recommendation for immediate action was the National Suicide Prevention Life Funding Line. The National Suicide Prevention Lifeline is expected to be implemented. I have to minimize my screen here. Through fees. Sorry, I'm getting used to a new system and I have to find, I was covering my document. The National Suicide Prevention Lifeline will be a national network of local crisis centers that provide support to people in suicidal crisis or emotional distress. It will transition from a 10-digit phone number to 988 by July of 2022, making it easier for individuals to know what number to call when in crisis. Some phone providers have already begun making this transition. The change is expected to contribute to an increase in the number of individuals using the suicide prevention line, which currently attempts to match callers to in-state crisis centers when possible. Between October 1st of 2019 and December 31st of 2019, 60% of NSPL calls from Kansas were answered by Kansas providers. What that means is that 40% were answered by providers from out of state. We would like to collect fees via phone bills to support increasing the in-state answer rate to ensure that when people call into Kansas, they're getting a Kansas-based response and connected to a Kansas-based provider as quickly as possible. The second immediate recommendation from the Prevention and Education Work Group was early intervention. We need to increase access to early childhood mental health services by including additional language in the Medicaid state plan to cover the cost of early childhood mental health screening, assessment, and treatment. Early identification of behavioral health symptoms for youth and children can allow for earlier intervention, leading to better outcomes for youth. Additional funds would be needed to continue and expand this work statewide, which has started with a partial pilot via the Substance Abuse and Mental Health Administration Systems of Care grant. From a child welfare perspective, we want to definitely look at intervening at the earliest sign of needing support for youth so that they can stay in their families and become successful and learn to manage their symptomology early. The third immediate priority for this topic was creating a centralized authority. We'd like to centralize coordination of behavioral health services, including substance use disorder and mental health, in a cabinet level position. A version of this recommendation was originally developed by the Governor's Substance Use Disorders Task Force. The centralized authority would help ensure that behavioral health efforts are consistently prioritized, coordinated, and reported on to the governor. Responsibilities of this position would be to ensure collaboration across the state agencies, to allow for coordinated efforts in modernizing the behavioral health system. One of the biggest challenges that you'll see if you read the baseline of the reports that have been created, that were reviewed in compiling this current report, is the problem of the silos across the systems. Child welfare is a separate system than the Department of Aging and Disability Services, is different than juvenile justice, and is different than KDHE and the MCOs. And all of those different systems without one common point can create barriers to a modernized mental health approach. The final recommendation of the prevention and education topic was more of a strategic long-term approach for behavioral health prevention. Currently in the state, we have the vast majority of our funding is put into treatment after behavioral health needs have emerged. Currently, only the minimum amount of funds within the substance use disorder block grant are allocated towards prevention. We believe that a modernized mental health system will balance prevention services with more of the treatment and intervention services so that we can help people identify warning signs early and receive treatment and support before their symptoms might escalate. The second topic that our group looked at was treatment and recovery. The treatment and recovery modernization vision is really about a data-driven, person-centered approach that looks at evidence-based treatment and promising practices and allows meaningful coordination across settings. Again, going back to that silo question. Entry into and navigation of the behavioral health system should be clear and consistent. A modernized system will support crisis services, including intensive outpatient, partial hospitalization, day programs, substance use, family residential treatment, and respite and crisis beds. The system, from a modernized perspective, will need to be developed to be flexible and adaptive to changing trends and data so that we can continue to meet the needs of Kansas. The first topic for our treatment and recovery subgroup was related to psychiatric residential treatment facilities, also known as PRTFs. If you're familiar with the PRTF terminology, we've been reporting over the past few years on a high wait list into the PRTF facility and questions about whether children were being able to access the medical care that they needed in a timely basis. We have seen improvements with KDADS, KDHE, and DCF working together to reduce the wait list and to increase the bed capacity among PRTFs. We want to continue for an immediate importance that the work on PRTF access continues as a priority of the state of Kansas. We need to ensure that youth who are most at risk in this state receive the care that they need when they need it. And we also want to include in that spectrum that we are looking at whether we have adequate services in the community before PRTF is needed to avoid it if possible. And also that we're working after discharge from PRTF to make sure that children and youth can be stable when they move on to a more family-like setting, which the PRTF is designed to support. The next more strategic long-term importance of the treatment and recovery group was looking at the service array. We simply need to look at expanding the broad behavior Kansas. This is in this recommendation, we highlighted medication assisted treatment in block grant services, but what our work group talked about is the need for just a broader access of accessible, affordable care for Kansas so they can access the appropriate quality level of services that they need. This examples for this time include crisis stabilization services, intensive outpatient, and other community-based options, which can reduce the need for stays in institutions. And we did want to focus on the medication-assisted treatment need because it is a real gap in our current system. This could include a focus on specific populations such as pregnant women or jails. We see this even among youth, that we need support for youth who are in withdrawal and who have and without adequate support tend to want to run back to their their drug of choice rather than staying and receiving the services that they need in their homes or communities. The second strategic importance of this working group topic is looking at frontline capacity. We're all aware of the shortage of mental health providers in the state of Kansas. And so we'd like to look at increasing the capacity of frontline healthcare providers, such as pediatricians, family physicians, and OBGYNs, to identify and provide services to those with behavioral health needs. If we can expand the knowledge base and capacity and referral services and support to frontline providers, we can expand the ability of our state to make sure that we're meeting the initial needs of those with behavioral health services without necessarily having to increase all of the capacity that we would desire. As a reality for our state with rural challenges in workforce. The final strategic importance under this topic is housing. As mentioned earlier, the need for concrete support so that folks who need to have assistance in housing or otherwise can not only receive mental health support, but also receive the support to maintain stability is critical. We'd like to expand and advance the supported housing program and the SSDI Outreach, Access, and Recovery Program known as SOAR. This was originally a recommendation from the Housing and Homelessness Subcommittee of the Governor's Behavioral Health Services Planning Council. The supported housing program provides affordable housing links for low-income, homeless, and potentially homeless individuals with a severe mental illness. We'd like to expand this support as broadly as we can and make funding available, while recognizing that funding alone will not address the other barriers to housing where we have a shortage of affordable housing altogether in certain parts of the state. The final subtopic for our group was special populations. And we looked at a modernized vision for special populations from the perspective of using data and having consumers and family needs drive the system development. Modernized efforts will be integrated again across those silos, proactive in identifying and responding to needs, and responsive whenever there is a need or a self-identified crisis of a consumer. We will use data to understand when there are disparities that should be addressed. And we will look at education, training, and agency to respond to those needs as we identify them through data and consumer feedback. We'll look at wraparound services and look specifically at special populations that we know are at increased risk of behavioral health needs and long-term healthcare needs, including those others that were all listed on the recommendation rubric that the special committee would have heard about yesterday from KHI, as well as individuals like victims of domestic violence, children of incarcerated parents, individuals with limited English proficiency, or pregnant women experiencing mood disorders. To begin with, for immediate action, our group developed a new recommendation related to domestic violence survivors. We see that domestic violence survivors have a uniquely high risk for identification of the need for support. 1 in 4 women and 1 in 10 men have experienced some form of intimate partner violence known as domestic violence. And we also know that domestic violence isn't limited to adult partner violence, but it includes violence against children in a domestic home situation. So therefore, domestic violence has multi-generational impacts and can impact children and youth who live in homes where domestic violence occurs. So what we would like to do, our group recommended building awareness of and responsiveness to the behavioral health needs and risks of domestic violence survivors of all ages through data analysis, information sharing, workforce training, and targeted interventions. While many community resources are currently available to support domestic violence survivors, those resources are not coordinated across our silos, and that's where we think we could have a strong impact by addressing and looking at those needs from a data perspective. The next immediate intervention in our final special populations analysis was parent-peer support. We'd like to increase access to parent-peer support for caregivers and families of youth, including those fathers of dependent children, to connect parents with lived experience who are navigating the behavioral health system on behalf of their child. The behavioral health system, especially when you combine behavioral health, IDD services, child welfare services, juvenile justice services, and other services that can be all needed in one population, it can be very difficult to navigate. Parent-peer support can be very effective in helping parents stay the course and understand how to navigate and support their youth. We'd like to look at this as a cost-effective strategy to improving outcomes. And the other piece is that peer support can create additional job opportunities for those with lived experiences, which, as we discussed, is a key in a modernized approach to behavioral health care from a treatment perspective. The more long-term recommendation for special population goes back to the crossover youth population previously mentioned. we have seen in child welfare and juvenile justice that there is crossover between youth who have child and family trauma and who have behavioral manifestations. And so those youth can be brought to the attention of the juvenile justice system, the mental health system, the substance use system, or the juvenile justice system. And you don't know where the youth may appear, but the youth may actually have similar symptomology that needs to be treated. And what we don't want is for youth to have to go farther into either the child welfare or the juvenile justice system in order to access the services that they need to meet their needs and to meet their needs for intervention. Although the population of crossover youth is not a large population, meeting the complex needs of this population requires a substantial investment of resources across agencies. So our recommendation is to continue to develop the linkages between the different systems and silos. And I would like to also point out, it's not only linking between the silos, but we need to provide the services that can meet the need of youth who are externalizing their trauma history in behaviors that are maladaptive and could end up leading them into the juvenile justice system. The second to last strategic idea for special populations is to expand the IDD waiver. We need to fully fund the IDD waiver and expand the services. We need to do this through reimbursement rates to support workforce expansion. Individuals with IDD who have co-occurring disorders are not adequately served currently in our state. We can see this from the behavioral health lens, we can see this from the child welfare lens, and we can see this from the juvenile justice lens. This is due to the challenge of finding providers who can address the complex interplay of needs with IDD. So we're hopefully that this committee will support fully funding the IDD waiver to reduce the wait list and increase access to services. The final recommendation of our group was to look at family treatment centers, which is family substance use disorder treatment, including outpatient treatment programs. This is an updated version of a recommendation originally developed by the Governor's Substance Use Disorders Task Force. Expanding access would allow more individuals to receive treatment by not requiring parents to choose between caring for their family and receiving treatment, which we see as a common dilemma. Treating individuals in a family setting can benefit the entire family by allowing the whole family to participate in treatment and therapy. I thank you so much for your support of this study and for the opportunity to present to you today and to the working group members and to KHI, and we'll stand for questions at the appropriate time. Thank you.
Well, thank you very much for your testimony. And committee members, we are now going to open it up for questions. And I do have a question for Andrea.
Yes.
Okay. Andrea, on 8.3, it had to do with the law enforcement mental health portion of the recommendations. Yesterday, the governor sent out an announcement that they have a program starting in KDADS to address that. There wasn't a whole lot of detail in it. I know she's waiting for a big press release on it later. But is that something that I'm sure KDADS is aware of? Is that something that you guys are optimistic will put a pretty good dent in that? Are there other things we need to do as well?
The Stepping Up Initiative Technical Assistance Center announced by the governor yesterday, and the KDADS initiative is really aimed at helping local communities address the number of individuals with mental illness in local jails specifically. So it's a project we're excited about that has shown success in several communities in Kansas, and we're hoping to bring Council of State Government resources in to really bring that effort statewide. The work group, I believe, is still supportive of additional measures and activities needed in this realm that are focused more also on diversion activities, specialty courts. There's really a whole spectrum of programs that will address this issue. But we are, KDADS is excited about the Stepping Up Initiative and believes that it will be a good tool in the toolbox for the state to really tackle issues at the intersection of behavioral health and criminal justice across the state. So,
Andrea, thank you. Committee members, do we have any other questions? Senator Petty and then Senator Erickson.
Thank you, Mr. Chairman. Andrea, this is also for you, and I was just wondering, it sometimes is a little unclear as to whether legislation is needed for some areas. So particularly on the change to opt out to get better data for drawing down federal money, that would take legislative change. Isn't that correct?
yes, there was specific legislation passed in the recent past that required those types of surveys, that parents would have to actively opt into them for them to be provided to or given to children within the school systems. And the result of that change was a pretty dramatic decrease in the number of responses, to the point that, there's questions about the efficacy and the usefulness of that survey data. So the work group wanted to advance the recommendation that legislation be reversed.
Got a photobomb going on there.
Yes.
Thank you, Andrea.
Senator Erickson.
Thank you, Mr. Chair, and thank you to all the presenters. I think this is a critical issue that we need to address, and I appreciate your hard work. And frankly, I think the person or the pet that is photobombing you is great for mental health. So my question is kind of two-part, and it's probably for both Rachel and Sandra. Coming from an educational background, we took the position, or the school took the position, that all children are traumatized. That was the assumption that we operated under, is that all children were traumatized. So my first question is that the assumption or the thought, the mindset of the folks who were working on the committee, and therefore the impetus for some of these recommendations? And then I do have a follow-up, Mr. Chair, if I may.
Rachel, do you want to go first?
I was going to defer to you either way.
No, the assumption was not that all children were traumatized. I think according to ACE's study, if you're familiar with that, there are different degrees of life events that can impact a child's ability to cope and be resilient. But we did look at those most vulnerable populations in the mental health system that do experience trauma. So that's why the emphasis on trauma-informed care, so that we are always cognizant of the fact that there is trauma in folks' lives, even those in the juvenile justice and the justice system. They've experienced some type of trauma. So I guess my answer is no and yes, depending on the scope of the population. And I'll turn it over to Rachel.
Well, thank you for the question. I think it's an important one. And I would agree with Sandra, your no and yes. Our group did not specifically look at the question of whether all children are traumatized. We know that it would be extraordinarily remarkable for any person to go through their lifetime without having some sort of a traumatic event. But that doesn't mean that we can't differentiate between higher risk populations who have more traumatic or more severe traumatic event, and who we really need to focus on resiliency and trauma-informed responses to their needs. So that would be how I would respond to that.
Okay, thank you, Mr. Chair. And if I will, just to follow up on that. So when you talk about screening, the screening of children, and then the Medicaid payment for the screening of children, who would be providing those screenings? What would be the reason for the screenings. I know in a lot of public schools, they have a behavioral assessment tool. Would that be implemented across for every child as just kind of a, like we do academic screenings, we're going to do a behavioral screening and then want reimbursement from Medicaid? Please speak to that. Thank you, Mr. Chair.
You know, I actually am going to have to either defer to someone else who is more familiar with the Medicaid early screening options. That's probably what I need to do, because I don't know if our committee was very clear when we articulated the need for this. I don't think we said for every child specifically. I think that the main challenge was that currently we don't have the Medicaid codes that allow it for when it would be appropriate. And so I would have to defer to other experts on the panel before I could say what exactly the framework or approach would be for rollout or implementation, but we know we can't start without the Medicaid codes to do it.
Yeah, and I agree with Rachel. I don't think that that was a primary focus of the work group, but it is a critical point in having the accessibility to screens and to assess where a child is. And I think it takes a multitude of venues or avenues into those screenings. So as you mentioned, the schools, the mental health centers, the primary care physicians, they all have a part in doing just the basic screens of what is happening in the behavioral health of the person that they are seeing.
Senator Gossage.
Thank you so much for the study, and thank you for your presentation today. My question is, it appears whenever we have a national, or in Kansas, a traumatic event where someone who was receiving mental health services, whether that be medication and or seeking psychiatrist help, still did horrific things. And so people have said, well, we need more mental health services in our country. We need more mental health services in our state. In your studies, what did you find in your research as to how much and if it really made a difference, particularly in preventive services?
I'll speak just very briefly. I think that's a really important question in space, and I appreciate that, Senator. What I would have to answer is that we in our working groups did not review or study the data. We brought our collective knowledge of the need for prevention and treatment. So I would either have to defer to potentially Kyle Kessler or others who would maybe have that data more on the top of mind, or look into working with KHI to get some of those statistics back for you.
Thank you. And a follow-up question, please, if I may, Mr. Chair. Also, we've seen teen suicides, particularly with the restrictions on going to school, et cetera, with COVID. And with these teen suicides, again, some of them have seen psychiatrists or been taking medication supposedly for prevention. Have you looked into any of that research or checked into studies about how many children have committed suicide or had other issues?
Good morning, Mr. Chairman. This is Kyle Kessler. Can you hear me?
Yes, Kyle, thank you.
Thank you, Mr. Chairman. And again, this is Kyle Kessler with the Association of Community Mental Health Centers. I apologize. I was struggling with technology early on, and that was a user error on my part. But just to address a couple of things, and I think Senator Gossage makes a couple of really good points. And we have studied this, and it was something that was even discussed in our working group with system capacity and transformation. And we're visiting about, I know Senator Baumgartner has been involved in the Attorney General's youth suicide group, and this is something that we're even seeing as recently as this year. According to the KDHE Summary of Vital Statistics, the number of youth suicides went down. We didn't even just flatten. We actually went down in calendar year 2019 for the first time in 7 or 8 years. And I think that this is somewhat due to, or in large part, due to some of the work that's been done by the legislature over the last at least 2 or 3 years, maybe 4 years, on a variety of youth mental health related issues. That range from funding to prevention, funding for mental health first aid, some of the different school mental health projects that have been discussed and embarked upon. So those pieces are absolutely part of our state discussion. And then at the national level, I know the Certified Community Behavioral Health Clinic model has been really successful in a lot of states, and even ramping up more school-based mental health treatment services. That was one of the bills that was introduced yesterday, along with the bill that earlier Senator Petty alluded to relating to the Communities That Care Act. That was also a bill that was introduced yesterday in your committee as well.
My
Thank you,
final
Mr. Chairman.
question, if I may, Mr. Chair, is
I'm sorry, Senator Gossage, but we're running low on times, and we have other questions from other committee members. That's fine. Senator Petty.
Thank you, Mr. Chairman. And this goes to Sandra with the telehealth group. And I just wanted to clarify. So you mentioned several areas that, and I would, with the facility fee, I know that was a discussion. Sorry for this feedback. Maybe it's the tea that's making this, I don't know. The facility fee, that would take legislation, or Kyle or Sandra, one or the other, to have that included, or we're talking about overall, we need to look at legislation when it comes to telehealth funding.
Thank you, Senator Petty. And Kyle, I think you can stop me if I'm going down the wrong path. I think this would be a policy change and not necessarily legislative change. A lot of the originating fee requirements go back to CMS, and so they have a say in how those are structured. But I think this would primarily be policy change. Kyle, do you have any other opinion?
I think it depends. I think for Medicaid related, it would absolutely be policy change. If we were looking at something with commercial insurance, and certainly Blue Cross and Blue Shield has been part of this conversation as well. So we look at those different insurance providers in different ways, if that makes sense.
Thank you.
Senator Thompson, did you want to defer, or do you have?
Well, I just, before we adjourn, I would like to just make a comment, not on this, but on a vaccination situation that emerged yesterday.
Senator Gossage, just quickly, and if we could get a response real quickly, because we do have a couple of off-topic subjects that we do need to address before we adjourn. So, Senator Gossage.
Very quick question. I'm wondering if there are any as part of your recommendations, do they include any faith-based partnerships?
And this is Kyle Kessler. And I don't know, Senator, if there is in this particular report. This is really what I would consider to be an encyclopedia of a report that builds on the work that was done in 6 or 7 other previous committees. And I think that there had been some of those types of recommendations made in the past, and they were pursued and implemented as possible. So there weren't any still remaining from the previous reports for us to review in this. And if others have remembered that differently, I would defer to them, but that's how I would see it.
Kyle, thank you. And we're running out of time, and we have a couple of things off topic directed to legislative research. Marisa, are you available real quick?
Yes, Mr. Chair, I am. Can you hear me?
I can, thank you. I'm going to turn it over. We have a request that we would like to send to KDHE, and we would like a response back by tomorrow on this. We think it's pretty urgent. And I am going to defer to Senator Baumgartner. She has a little bit more knowledge of this event, or thank you, Senator Baumgartner.
Thank you, Mr. Chair, and I just want to say thanks. I was able to listen to the entire meeting via phone up until until I got here. So yesterday, we were in our joint meeting with the House, and we heard from the Secretary about the rollout for Phase 2. What he didn't share with us is the largest distribution that was planned for, Johnson County, and we had 65-year-olds and older. And if you see any of the news footage, we're talking about 75, 85-year-old folks. And the distribution was set up in a sports complex, so these folks were in walkers, wheelchairs, and their caregivers were there, and they were standing out in the 20-degree weather, waiting in lines for hours to get those injections. And we need to know from the Department of Health just what exactly they're doing to make sure in January and in February that folks are going to have access and they're not going to have secondary problems because of inappropriate planning. The other concern that came up is those 63 different extended care homes that are not covered by or guided by CMS. We understand through some communication back and forth that the individual residents are needing to contact their community health care to schedule get their injections. And again, that is unacceptable. These folks, for them to have to call, to try and schedule, then to come up with transportation, where we already know their living situation is prohibiting them from having meals together with others, doing any of those other congregate activities, and yet they're to organize that transportation elsewhere to get the injection. Unacceptable, and we need to know what that plan is now that we are in officially Phase 2. Thank you, Mr. Chair.
Thank you, Senator Baumgartner. And Marisa, if you could get that to KDHE as quickly as possible with a request to have that back for us by our meeting tomorrow, we would appreciate it. Committee, we are adjourned. Thank you.